Very, very simple. You should also, we've seen quite a spate of these, don't ever forget non-diabetic ketoacidosis. Okay, there's no excuse for not looking at this. When you get your blood gas, you can just go down and you go to the little bit that says AG. And if it's a really high number, then it's going to be one of those 4 causes. And then and then you go lactate. Oh, it's on the gas itself. And then you go glucose for ketoacidosis. And then you go look at the renal, you get your urinase because they're coming back and the urea and creatinine. And if you can't explain it from those, then you start thinking, And you should then start wondering if it poisons, but they're very, very rare actually. Most patients actually tell you up front that they've taken them. Or there are other causes of ketoacidosis, and get them to dipstick the urine. And we've been called up a number of times and go, oh, there's no need to dipstick the urine, the glucose is 9. Just dipstick the urine, 4+ ketones, then ketotic. And starvation, alcohol, and other things, androgenic storms are quite common. And we've even had a patient go back to theatre who had a very small bowel operation, back in recovery, not a bit tachycardic and a bit of abdo pain, not really. And then someone did a gas, terrible acidosis. They thought, oh, this is no good, and they actually took it back to do a relaparotomy to find nothing. And actually, what she had was ketoacidosis. And what we need to do is dipstick the urine. And so just be aware of that. So there's the 4 causes, and if that's too hard to remember, I once was told, this is from Wikipedia, kill you, but I'm not sure where it is. Ketones, ingestion, lactate, urea. Very, very simple. Can't remember. Only 4 causes, okay? And 99.99% of them are the first 3. No, the first 3. Ketones, lactate, urea. Ingestion's really, really rare. So, let's go on to normal anion gap. So let's look at this, what's happened next time. So this is the next day for our patient. You see that I've given you the Boston rule. He should be 4.2. He's 4.1. That's great. He's perfectly on the thing. He's had his surgery. He's now got a base excess of minus 8.8. You worried? He was minus 8. Now it's minus 8.8. He's getting worse, isn't he? Is he or not? So what's happened to his anion gap? It was 22. It's now 11, which is basically it's normal. And what's the most likely cause for that? If you're a betting person, you'd say that's
saline poisoning.
Saline poisoning, chloride, yeah. And so now he's got a normal anion gap metabolic acidosis with appropriate compensation because he's following the Boston rule, and his chloride happened to be 121, which we caused. So what are the causes of a normal anion gap metabolic acidosis? Well, some of the causes, you're obviously losing your bicarb, you've got an acidosis. And because of how you're losing it from the body, you're losing a sodium at the same time as you're losing a bicarb. So you can actually, and therefore if you do that, your gut won't, if you do that, there's no change. Let's look at the first cause, the gut. And very simple, I'm not a surgeon. There's a top gut, there's a bottom gut, and there's a middle gut. So what's the bottom gut as a cause for acidosis? What can cause an acidosis from your bottom gut?
Diffuse diarrhea.
Diffuse diarrhea. Middle gut, if you look through the textbooks, if you've got an ileo, some sort of pancreas, basically if you've got funny plumbing inside you, you can get a normal anion gap acidosis, and the textbooks will talk about that. What's your top gut for acidosis? What can cause an acidosis from vomit? What's that?
Is it from the middle gut?
No. Just vomit. Someone say vomiting? But doesn't vomiting lead to an alkalosis?
Yeah.
So how do you get an acidosis from vomiting? Because vomiting is the right answer. Yeah, but then usually you're getting a lactic acidosis and stuff. Who should I pick on? This fine strapping gentleman here. So you remember when you were a medical student, and you may well have overindulged in alcohol, maybe. And then here you were one night vomiting in the gutter, maybe it's just Australian medical students, and you're vomiting in the gutter and you go, carrots. I'm a student, I don't eat carrots. Where's the carrot gland? Answer that question, you can answer all of this. Where's the carrot gland?
The pancreas?
Yeah. Do you know, what colour is your vomit?
Brown.
Brownish, greenish even?
Brown.
Bile. See, adults, when we vomit, we tend to regurgitate small intestinal contents into our stomach, and that's what we vomit up. And that's why you get a mixture. And that's why adults can often predominantly vomit bilious substance, so therefore bicarb, and therefore that's why they get an acidemia. If you're a baby with pyloric stenosis, you can only ever vomit pure alkalines, pure acid and become alkaline. If you've got a nasogastric tube in with gastric outlet obstruction, you're losing 4 or 5 litres a day, you're losing acid. The rest of us tend to lose a mixture, and especially the adults, we tend to lose a lot of alkaline substances. There's a second cause, renal. And this is where your renal tubular acidoses are. And there's quite a lot, type 1, 2, 4 and the things. In my career, I've never seen one come to ICU. That's how sick they are. They're not very sick at all. And so, maybe the renal physicians will tell you more about how important they are, but I've never seen one that's remotely given me, most of them I've never even noticed were there, and they don't become very sick. So they are there, but they're not really a major cause. You can sometimes get normal anion gas acidosis in the polyuric phase following renal failure, and therefore you turn your high anion gap renal failure acidosis into a normal anion gap. And then at the bottom is chloride. See, chloride going up there, you see that? And if chloride goes into the body, a la Stewart, you've got a negative charge, you've got to reduce either the negatives or increase the positives, and the simple thing to do is to reduce the bicarb, and the gap won't change. Why do you get hypochloremic acidosis? Very simply, because you've got a chloride of 100, and every bag of normal saline's got 154, so you're driving up by 50%, or once it'll be diluted out, but the drive is that increasing by 50% with every bag, and Hartmann's is 111 and Jello's 120, and all the things we give pushes the chloride up and up. So is hypochloremic acidosis bad for you? Some people think it is. Some people call it, saline poisoning or hypochloremic poison. They've done trials where they've given some nice fit young medical student males 3 litres of normal saline, and the other one's got 3 litres of Hartmann's, and all the ones that have got normal saline said, "Oh, I've got a bit of tummy pain, I don't feel so good." Unless you're doing private anaesthesia, I don't think you'd really care. That's not really enough to make us concerned about. What worries me though is the iatrogenic injury that can occur. So you see Mr. EW, our man, and his basic test is -8.8, and you go, "That's no good. It was at -8, now it's -8.8. That's bad acidosis. I better give him some more saline because that'll help him." And that's what happens. And then you can get your pulmonary edema and your anastomoses because people look at that. And I think most people get better because they look better and we stop doing gases on them, not because they can actually, and they are getting better. But the moment we start looking at gases, we can find ourselves doing treatments we shouldn't be because we don't understand. So, in way of summary, from a ramshackle view, you've got to have the right nomenclature, hemianosis, because that gets your brain thinking properly on this topic. It's very easy to see a mixed picture for most of them. If they're ever going in opposite directions, bang, mixed picture. Tells you straight away. There are rules to help you judge acute compensation. It's not about normalising the pH acutely. Chronically it may be, but acutely, and what we're interested in, ED, on the ward, and especially intensive care as well, it's always acute, so you never have a normal pH. And you can use the Boston rule for metabolic acidosis. There are rules for the other conditions, but they're not so relevant and not so practical and so helpful, to reset the normal. And it resets the normal, and that's how you judge compensation. And there's only 4 causes of a high anion gap acidosis, and since anion gap is written on every single blood gas, AG, and if the number's sort of about 15 or 20 and above, it's a high anion gap, and there's only 4 causes: KIL-U, ketones, ingestion, lactate, urea. And there's only 3 causes of normal anion gap acidosis, which is usually in the story, and the chloride itself is on every blood gas, so you can see it rising. And that's all I know. Any questions from this run through? And that's a chap who helped me learn all about this, and people know him from the Physiology Viva book in Australia.